Let's talk about the calcaneus fracture. For any orthopedic surgeon, just hearing those words can make you a little uneasy. This is, without a doubt, one of the most challenging injuries we manage. It's almost always the result of some kind of massive, high-energy event. A fall from a significant height, a bad motor vehicle accident, and the fallout for the patient can be absolutely devastating. And here's the number that really tells the story. 75%. Three-quarters of these fractures are what we call intra-articular. Now, what does that mean? It means the fracture line has smashed right through the critical subtalar joint. That's the joint that lets your foot tilt and adapt to uneven ground. Once you disrupt that, you're setting the stage for a whole host of long-term problems. And this quote from OrthoBullets really drives the point home. We are not just talking about a simple broken bone here. We're talking about an injury that can fundamentally alter someone's life, often leading to chronic pain, stiffness, and significant disability. So you can see why understanding this thing inside and out is so crucial.
So, here's our game plan for this explainer. We're going to take a clinical journey, starting with how we classify these incredibly complex fractures. Then we'll get into the imaging, dive into the big debate on how to manage them, face the tough reality of complications, and we'll wrap it all up with some really high-yield evidence and clinical pearls.
Okay, first things first, classification. When a surgeon is looking at an x-ray that just looks like a bag of broken bones, the very first job is to bring some order to that chaos. Classifying the fracture is how we start to wrap our heads around how bad it is and how we might even begin to attack it.
The very first fork in the road is pretty simple. Does the break go into the joint, or does it stay out? About a quarter of the time, they're extra-articular. They stay outside that critical joint surface. These are often things like avulsion injuries, where a ligament just yanks a piece of bone off. But the vast majority, that 75% we talked about, they're intra-articular. They crash right into the subtalar joint. And those are the ones that give us the real headache.
Now, for these really complex intra-articular fractures, the Sanders classification is pretty much our go-to system. The key thing to get here is that this is all based on what you see on a coronal view of a CT scan. It basically just counts the number of major fracture lines going through the main weight-bearing part of the joint, the posterior facet. So a type 1, basically non-displaced, not too bad. A type 2 has one fracture line, splitting it into two parts. Type 3, 2 lines, 3 parts. And a type 4, well, that's the worst case scenario. It's completely shattered into 4 or more pieces. And you can bet the higher the Sanders type, the worse the patient's prognosis. So how do we actually see these fracture lines and make these calls? Let's move on to imaging. This is all about getting a clear picture of the injury and using some key measurements to really quantify just how bad the damage is. And let me be perfectly clear about this. While your standard x-rays will probably give you the initial diagnosis, the CT scan is the undisputed gold standard for surgical planning. There's no debate. It gives us that crucial 3D picture, which lets surgeons really, truly understand the fracture pattern, classify it accurately with the Sanders system, and then map out a surgical plan down to the millimeter. Back on the plain x-ray, though, one of the most important things we measure is something called Bowler's angle. It's formed by these two lines you see here. And what it's really doing, in simple terms, is giving us a sense of the height of the calcaneus and the structural integrity of that all-important posterior facet. In a normal, healthy heel, this angle should be somewhere between 20 and 40 degrees. But what happens in a high-energy injury? The calcaneus gets crushed, it collapses, that posterior facet drops down, and the angle gets smaller, or as we say, it flattens. And this is exactly why it's such a powerful tool. Studies have shown that if you measure a Bowler's angle of 20 degrees or less, it's an incredibly accurate sign that you're dealing with a fracture. And a severely flattened angle, especially one that's less than 0 degrees, well, that's a very, very poor sign for the patient's outcome. The other key measurement you'll hear about is the angle of Gissan, sometimes called the critical angle. Normally, it's around 120 to 145 degrees. When the bone breaks and the pieces get impacted, this angle often gets bigger. It's another useful piece of the puzzle for assessing just how much collapse has happened. All right, now we get to the absolute heart of the matter, management. This is the central conflict, the big debate in treating calcaneus fractures. To operate or not to operate? A surgeon has to carefully weigh the potential upsides against some very real and very serious risks. So what are the two main paths? Well, on one hand, you have non-operative treatment. You put them in a cast, tell them to stay off it, and you completely avoid the risks of surgery. The downside? They might end up with a deformed heel, loss of height, and a very high chance of getting painful arthritis down the line. On the other hand, you have operative fixation, ORIF, or open reduction and internal fixation. The goal here is to put all those puzzle pieces back together perfectly. But, and this is a big but, it comes with a huge risk of wound complications, all because the skin around the heel is just so thin and fragile. So when do we say, no way, we are not going to the operating room? This table gives us a pretty clear roadmap. We look at patient factors. Are they a smoker? Do they have diabetes or poor circulation? All of these things skyrocket the risk of wound problems. And we also look at the fracture itself. Is it a non-displaced Sanders tape 1, or maybe an extra-articular fracture that's barely moved? In those cases, the risks of surgery just plain outweigh the potential benefits. And this quote just captures the dilemma perfectly. You could go in and do a technically flawless operation, put the bone back together like a beautiful piece of art, but then a major wound complication can come along and just wipe out all of that hard work. That soft tissue envelope around the heel is incredibly unforgiving, and that fear guides every single decision a surgeon makes. Which leads us, of course, straight to the aftermath, the complications. Look, no matter which treatment path is chosen, complications are a very real, very common part of this story. And it's exactly why these injuries are associated with so much long-term trouble. And we've got the hard data to prove it. This chart here is from a study on operative fixation, and it shows an overall complication rate of nearly 27%. Just think about that, more than 1 in 4 patients. And look at the breakdown. Chronic pain is the biggest slice of the pie, but it's followed very closely by wound necrosis, where the skin dies, and deep infection. These are not minor issues. These are huge problems that can mean more surgeries and a brutal recovery. And even if you manage to dodge those immediate surgical complications, the long-term outlook can still be pretty challenging. Post-traumatic subtalar arthritis is incredibly common. Malunion, where the bone heals in the wrong position, can lead to a heel that's too wide and too short. It won't fit in a normal shoe and can cause painful rubbing of the tendons on the outside of the ankle. You throw in the risk of nerve damage and chronic stiffness, and you really start to see why the outcomes for these injuries are so guarded. All right, let's start to bring this all home by distilling everything down into some key evidence and clinical pearls. This is the really high-yield stuff, the things you absolutely need to have in your back pocket for exams and for clinical practice. So, where are things headed? Well, the big question is, how do we get the benefits of surgery without the massive risks? And this is where the newer evidence is pointing. A recent randomized trial looked at minimally invasive techniques, using tiny little incisions and screws placed through the skin, and found they had 0% wound complications. Compare that to a staggering 30% in the group that got the traditional big open surgery. This could be a total game changer. And finally, let's do a rapid-fire round of Viva pitfalls and buzzwords. These are crucial. 1. Always, always, always check the spine. There's a 10% rate of associated spine fractures from the same fall. 2. Smokers and diabetics are huge red flags for wound healing. It's a relative contraindication to surgery for many. 3. Watch out for the tongue-type fracture pattern. That fragment can put crazy pressure on the skin at the back of the heel, so you have to splint them in plantar flexion to take the tension off. 4. What are the bad signs? A Bowler's angle less than 0, being a workers' comp case, and having a job that involves heavy labor. And 5. Know your exit strategy. A subtalar arthrodesis, or fusion, is the most common salvage surgery we do for the painful arthritis that so often follows these injuries. And that leaves us with this final, big picture question. This injury really sits at a crossroads. With such a tough recovery and such variable outcomes, is the answer to keep refining our minimally invasive techniques until they're perfect? Or should we be focusing more of our energy on preventing these terrible high-energy falls from ever even happening? It's a tough question, and it really defines the ongoing challenge of the calcaneus fracture.